Do you know, I'm so honored that you guys invited me up. I mean, imagine if, you're working in an isolated environment and, you got like some tricks. Because these are just some things that actually work. Can you fire up the PowerPoint? Okay, so when it comes to scoliosis correction, we're going to cover a couple of things, but we're going to go over the neurologic components of it and how you can predict it. Because this right here, the gal with the red line through, so frustrating. We're going to go over her case a little bit later, but she did not need the steel rods, and I can't take them out. I mean, they won't let me. They remove the bones to put that in. So when we take it, first off, these guys are brilliant. Okay, I utilize their research, okay, in a lot of the reports I do I only take like about 3 to 5%, insurance, like usually auto accidents, but their research is spectacular. Awesome, thanks, Doc. Okay, so now, but their biomechanics is brilliant. I do a lot of their techniques, but I don't have their machines because I'm not set up for it. But pressure over time, the mirror adjusting, the drop table technique, when you're seeing, 120 people before lunch, okay, you got to utilize the drop table technique to have a long career. Otherwise, it's not going to work. Now, there's a lot of different things. Stuff I used to do like the cross crawl exercise that she's doing on the stair stepper is phenomenal because it changes proprioception. And if you can change proprioception, you're going to change actually how the body views its position in space, and you're going to change the paravertebrals. Because if you can change the tone of that paravertebrals, by gosh, you're going to change the scoliosis. So those are really good. I don't do it. Okay, because I used to, and I didn't see as good a results as doing what I ended up developing. The chairs and stuff I would love to do. The Leander table, brilliant, because it's just biomechanics. So when you come up with cases that you're not sure how to do it, just think mechanically and think neurologically. If it's bent that way, you're obviously going to push it in. If you're missing a lateral curve or a lordotic curve, you got to restore the curve, okay? And the best way you can do that, you're going to get results. Good, bad, and ugly. I like the analogy. Okay, have you ever heard of carpal tunnel syndrome? You've heard of that? Okay, it's a double crush injury, begins in the neck, leads to a muscle imbalance of the forearm. Okay, normal strength ratio of the forearm is 5 to 4, the flexors versus extensors. So do you know how to make a muscle imbalance worse? You brace it. Okay, now is that stupid or stupid? Okay, yeah, we've got 100% success rate curing carpal tunnel syndrome. I mean, that's like basic. You guys do that. So if you got a muscle imbalance or a defect in proprioception, what barbarian would come up with bracing it? Okay, I mean, the only brace up there that's acceptable is the one that allows movement, because at least that way, you're applying some kind of force load on the spine, but, if you're not changing the neurologic component, it's not going to work. Is the good, bad, and ugly analogy too old? I like Clint Eastwood. Okay. Now, good, stress x-rays. This is going to be dynamic. Now, you get a patient in. How can you tell them if you can help them? You want to know? Okay, this is kind of cool. Okay, you take it and you bend it. That's all. All you got to do is bend it, because that right now, we're not changing the shape of the disc, which is what you can do. Heck, you can even change the shape of the bone. It takes 3 to 5 years to see bone changes on x-ray. What we're doing, we're just seeing the limit of the structures involved. So we're just checking the limit of the discs, ligaments, the stretch receptors of the muscles. You're not checking anything. So any decrease or change in that scoliosis is the minimal amount of correction. Wait, did I say minimal or maximal? I meant minimal. This is the littlest part that you can fix, okay? So you can say, no matter what the curve is, if you don't change, I'm not going to be effective. If it does change, that's the minimal amount of correction. So stress x-rays are fantastically vital. Now, when you're predicting this, we're going to go over the function of the paravertebrals, but you got to know, in order to tell the patient, okay, this right here, and you're going to see that's her lateral cervical curve. Obviously, anybody with a scoliosis, the normal spine has got the lordotic and kyphotic curves. 100% of scoliosis have missing the kyphotic and the lordotic curves. And since the body needs those curves for shock absorbing, by gosh, they're going to get it up. Okay, they're going to get a curve somewhere. So if you restore the normal lordotic curves, you got it. But now it's hard to see in the back, but there's tons of osteophytes in that mid-thoracic area. So if you're just looking at a static x-ray, you can say, hey ma'am, you got some severe degeneration here, I don't think it's going to work. No, you guys are Chiro 1. You're not Chiro 2, Chiro 3. Okay, this is number 1, okay? So bend it. I mean, in my health talks, I had this one gal who's got a reverse curve. It looked like a rib fuse. In my ignorance, I put phase 4 degeneration. Phase 4 is done, it's fused. I go in 90 days later and I see a disc reappear. Oh, okay, I didn't know. Okay, so you can't, don't prejudice your views by seeing osteophytes or something you think, because we're looking at shadows that could be off. So go in there and bend it so that 32-degree curve can be reduced down to 9 degrees. Now, is that the maximum correction or the minimal correction? Minimal. I mean, it really, really is. Okay, so then when you look at this, anybody that comes in with an MRI, you know how accurate that is? Like nothing. It's worthless. If you're looking for a soft tissue lesion, it's actually very, very accurate. Okay, if you're looking for a disc, if they're doing the standard MRI, it's completely ineffective. And what happens is, if you take someone, and it's a non-weight bearing MRI where they're laying down, 80% of asymptomatic people are going to show a positive disc bulge. Why? You're laying on a flat metal plate. Okay, so they're going to look for a disc bulge, but discs are not the problem. Discs are tough. Okay, so when you look at this, a weight-bearing MRI is vital. I like this quote from the AMI Guide Notes. What's the failure rate in back surgery? I've been using the quote 83%, but my son came across some new data. He's in chiropractic college. He says it's over 90% now. So if you fail at something over 80% of the time, should you change your protocol? The AMA says, so the failure of medical and surgical investigations result from looking in the wrong place at the wrong time. No kidding. Okay. Now here, okay, in the middle this is the neutral film. Okay, have you ever worked on a case and you thought, well, he came in with a disc bulge at L5S1 according to the MRI. Okay, and you're working on that L5S1, you're looking at this, and there's some rotational malpositions and buckling in there, but where do you work? Okay, what if you're not getting the results? I mean, I'm kind of obsessive about the whole chiropractic thing. The body, health is a natural state, so if he's not getting better, whose fault is it? Okay, it's because I'm missing something. And I'm pretty friggin' obsessive, so I'm not going to miss stuff. So what you do, you take this patient who's got the BS MRI and you bend it. Why? Because when you take that spine and you bend it, the discs should open up like what you would think they would. They'd open up like a book. So they should be narrow on the concaves, or the concave portion, wide on the convex portion. So you should see this type of bending. So when you look at this, bending off to the right, you can see that one disc. I mean, it's kind of hard to see because you're 40 feet away and it's a PowerPoint, but it's actually wide on the concave portion. That means that liquid center, or it's locked in on that area. It's not working correctly. You got abnormal dysfunction. So now that could be anywhere between a disc problem, or the facets could be off, causing an increase in tone of the muscles. There's something funky not right there, okay? Because do you have conscious control of the muscles that run down either side of the spine? Okay, now, I actually sold an x-ray machine, my old digital one, and now I got a direct capture. Like, a direct capture is like the greatest x-ray machine you could ever possibly hope for, and that was my present to me this year. So I sold it to my old one to a chiropractor, and he asked me what I was doing with it, and I showed him these x-rays, and I said, well, you don't have conscious control of the paravertebrals. He says, yeah, look, I can lift my head. Okay, he was, graduate from those partial schools. So when you look at this and you flex the spine, it clues you into abnormal dysfunction. And it's not muscles, but I mean, you got to figure if those facet joint, or the mechanoreceptors in the facet, if those increase or decrease tone of the muscles, it's going to alter disc motion. So this is going to show a disc bulge or stuff that is not going to show up on an MRI. And sure enough, I mean, this guy had the disc decompression machines, you know, the things that just pull you. Okay, do those work or not really work that good? You know what the statistics are? They don't. Do you know why they don't work? And this is how you can tell your patients, if your spine's bent off to the side and you're just doing an axial pull or pulling that along an axial traction, does this thing need that or does it need this? Okay, you got to look at it three-dimensionally. Okay, that just makes more sense. Now, discs are rarely, if ever, the problem. Okay, remember way back in human dissection? You could take a probe, like a pen, and pass it through bone pretty easy. You can't beat it in a disc with a hammer. Okay, so discs are incredibly tough. People are thinking that they break or herniate or mess up. It takes years for a disc to break down. You got 80 interconnecting rings of ligament. And this is exactly what I explain to my patients. By God, a disc is 80 different interconnecting rings of this fibrous tissue. It's like fiberglass. Imagine fiberglass this thick, because that's the size of a disc. It's impervious. Now, a disc has horrible blood supply. If you look at the actual weight of the body on this L5S1 disc, it's ridiculous. So that means blood vessels would be crushed under that type of force loading. And if you do something wild like bounce, okay, what did I do? I just increased the pressure on my L5S1 disc, probably 4 or 5 times normal. I mean, not as bad as what you're doing now. Well, I mean, you know, golf, bending forward, turning and twisting increases the pressure on the L5S1 disc 8 times normal. Okay, so if you say, man, I've been golfing all day, my back's sore, yeah, no wonder you're golfing. And you should be happy you're out there and not in here working. He's increasing pressure on the L5S1 disc 5 times normal. So if somebody has a sedentary lifestyle, except he doesn't feel it because when he flexes or bends forward, that joint opens up, or the IVF opens up, so it takes pressure off the nerve. So he's reversing the disc just sitting. So it's like, oh my gosh. That means that any type of person with long-term low back problems or a sedentary lifestyle, they're going to have disc injuries. Okay? So now here, this is an artificial fake disc. There's an AP and lateral view on the left-hand side. And she had the surgery. The pain was still there. Now, does anyone see a misalignment anywhere else in the lumbar? Yes or yes? Yeah. What does the AMA say? They're working in the wrong place at the wrong time, in the wrong direction, in the wrong. No wonder it's 80% failure rate. Actually, more than 80%. So she comes in, and she already had, they said, don't worry about it, we're going to do another surgery, you're going to be fine. No, they're working in the wrong place. They're not looking at this. They're not respecting that disc doesn't break down unless it has abnormal force loading. So now here, 7 back surgeries, and you can see, same thing. It's above the surgery site is where the problem is. If you got a dysfunction of the disc at the bottom, it's not that problem. It's not the disc. It can't be. It's got to be some type of alterations in mechanics above. So it's just crazy. So do you work on post-surgery sites? I got a list of 7 questions to ask patients from, because they come in from all around the world, and, unless they're going to Chicago, Kentucky, or Texas, I don't know where to send them. So one of the list of 7 questions to a chiropractor is, do you work with post-surgery cases? Why? Because if you do, that means you're probably at a higher level. Okay, do you take pre and post x-rays? Yeah, man, okay. That means you're doing some really good work. So now here, when I was teaching, and I'd always guest lecture at the human dissection, I'd say, and this is kind of the nasty teacher, but it's the home life I grew up in, we're kind of sarcastic. Would you want to loosen up the muscles in order to allow the body to accept the adjustment? What do you think most of the students said? Of course, yeah, except you'd be killing the patient. For every 1 inch that heads forward, the pressure on the discs double. So when you look at this, the body is going to fire off those paravertebrals to reposition that head, and if you relax those muscles, it falls further forward. And you can see that in scoliosis, I've never seen a normal curve, in the normal ordotic curve in the scoliosis. It doesn't exist. So the way that you correct that hyperkyphosis is to get a normal ordotic curve in the neck area. Now, this, when you look at it, and this goes on crazy dumbness that's still being perpetuated today, they say that muscles on the outside of the curve are weak. That can't be, because through intramuscular EMG studies, we know that it increases in tone. Do you have conscious control of these muscles? No. They increase in tone under proprioception. You got these little tiny facet joints in here that have little mechanoreceptors. And this is exactly how I talk to my patients. Honest to God. Okay, they got little mechanoreceptors, so if they're open up, they're actually going to increase the tone of the muscle. The real problem is the concave portion. And so when you're looking at this, you can't say to the average patient, look, you got a joint mechanoreceptor problem on the convex portion. They'd say, wow, that went over my head like the two people that recovered from death joke that I did earlier. Okay, so when you look at this, the facet joints, the body's trying to correct itself. So you look at the body, and you can even do this when you're palpating. When you're looking at the person and they're going face down and you're scanning them, anywhere that you're going to see a convex portion, there's going to be increase in tone of the paravertebrals. So now here, yes, that is a jigsaw from Home Depot. Okay. Pettibone designed it, but I didn't like that his was battery and didn't have variable speed. So this is just a jigsaw with furniture ends on it. You can call it the Burgalator. You know, Bergman, Burgalator. Okay, so you just pass, okay, you're not working on the convex portion, work on the concave portion. And this also works if you have a table, like you get a really hot low back, you can put them under abdominal suspension. Why? Because that's going to open up the disc area. It's going to create a negative pressure on the anterior aspect. That's going to suck that disc material back from where the nerve is up to the front. You vibrate that thing. I don't care about the hottest disc in the world. It's going to be able to accept it. And then you drop on it. Oh, my God, you're going to get some good work. So now here, this is Lauren, and the worst area you can get, because the rib cage area, the upper thoracic area, the cage itself is designed like a triangle. Why? Because you can hold a huge weight on your shoulder. I know. I used to carry my girlfriend's purse. Honestly, okay, has any man in here carried your sweetheart's purse? Okay, you know what I mean. Okay, so that rib cage is at an angle to support that great weight. So you got these big, heavy bullhorn ribs, so any correction in that area is really, really hard. So what you do is you take a stress x-ray. Can you help it? Yeah, so 18 degrees, that's the minimal amount of correction that we can get. Not maximum, minimum, because we're not changing anything. We're just changing proprioceptive firings. We're seeing the ligaments, the maximum amount of it. Her post x-ray at 9 months dropped it down to 15, which was wild because before she'd been at 18 degrees. So guess what you do when you suppress your correction? You take another stress x-ray. So that's it. So now her new goal, she went from 24 degrees to 15 degrees. Now her goal is 12 degrees. That would be better. I know, isn't that cool? It's like goosebump stuff. It's like great communication. So now this, to adjust this area, particularly in scoliosis, use the ribs. When you think about it, that rib comes around and attaches to the vertebral body. It's hard to get into the vertebral body because you think that they're about 2.5, 3 inches deep, depending on the musculature. But if you got that rib going, you can actually start using that as a contact. So when you look at this, now this gal here has a left thoracic rotation. Now, I do a lot of head rotation. So if you have a rotation where those things are done, when you turn that, okay, when you turn that head, because you can see it's left rotated on the plastic spine, when you turn the head to the left, that derotates or rotates all the spinous processes, okay, off to the contralateral side. So think about this, and this is also exercises. I do a tremendous amount of exercises that puts responsibility onto the patient. So if you have a rotation where all the spinous processes are shoved off to one side and you turn your head, it rotates them over to the side that's supposed to go. Okay, does that make sense? So if you see someone with a massive left rotation, say, hey, look, you work at a computer. What I want you to do, I want you to turn your head just slightly to the left. Okay, just move your workstation over. That's going to derotate it out. Why? Because I know it makes sense, doesn't it? I know, isn't this cool? It's like, hey, this is working for me. Maybe you guys can come down and show me what you're doing. Okay, because we're all learning stuff, okay? Because this is a high-level stuff. How many books are written on corrective chiropractic care? Almost none. This is it, man. This is the friggin' Mars mission. Yeah, so on adjusting, and this is the line of drive. This is the key. What I do on thoracic adjusting is, you know how you do an A to P? In fact, could I have a model? Anybody? Well, not yet. Sure. Okay, so now this, you already know, to adjust on your back, mess face up. Thank you. Okay, so when you're adjusting, okay, remember, they're missing the lordotic curves in the neck and low back, and they're missing the kyphotic curves. But also, if there's a rotational malposition, you also want to make that easy. So, and I know it's hard to demonstrate a line of drive, but one of the most frustrating thing is when people come in and they thrust like that. Because if they're taking antidepressants or cholesterol meds, you might get that mid-axillary audible. What's a mid-axillary audible? It's called a fracture. Okay, you don't want to do that? Okay, that sucks. Okay, so no, I'm not going to give you mid-axillary audible. So now let's say that her rib cage is rotated. So what I do is I'll grab the table and use the line of drive where it's just a real gentle thrust. But to pick her up, I'm going to lift my back leg so I can use gravity to lift her up. So it's just a real gentle move. We're going back, palpate down. But if it's on the left, I'll put my hand way over on the left-hand side. So almost at the apex of where the rib is. So my palm's over there. My line of drive is going to be the elbows through the hand, but I'm going to rotate over like that and then just have a little gentle thrust. It's that easy. If it's rotated to the right, it's the same thing, where I'm going to rotate, grab the table, and apply a little bit of pressure like that. And you can get way over where I'm just using my body pressure, and it really only takes that much pressure. But you start getting that right or left rotation. If you have a lumbar scoliosis, it's the same thing. Do you have any rotation in the lumbar?
Yeah, and roll right at L1.
Okay, it rose to the right? Yeah. Okay, so this is the same thing, where you're going to lift her up right down at the lumbar, rotate way over, and you're going to get just a really gentle motion. I know, isn't that cool?
Yeah.
I know, I love the adjusting thing. Thank you. Yeah, so it doesn't require a lot of thrust. You're just using a real gentle pressure. You'll feel it go, and then that way they're not scared of the adjustment, because it's that whole thrust thing that's a bummer. Now this is demonstrating on the other side. So it's just that palm contact on that ribs, because the ribs come in, and you figure they come in, they attach on the anterior aspect or the body. They're covered by that huge muscle, and then it comes up here. So your contact is actually on the rib itself. Okay, does that make sense? Okay, so now here, oh, good. Yeah, this is the fun part. Okay, this is going to be the exercises. Now, let's say you got Nancy, the gal who I just showed you with the massive right rotation, okay, in the T1 through T4 area, cardiac palpitations, all set to die, okay, because if that's sympathetic nerve supply down to the heart, that's ventricular fibrillation, that's death, okay? So this is one of the greatest exercises for it. Now, this is demonstrating a left thoracic, okay, left upper thoracic curve and a right lower thoracic curve. Now, if you got the scapula, and the scapula, if you raise the arm, the scapula pivots at an angle. So you got this triangular shaped bone. If you raise it up really high, it pivots, like in the middle there, it pivots up high. So if you have an upper thoracic curve, you're going to raise your hand up. If you have a lower thoracic curve, it's going to be down here. So this one, she's going to hold this for 1 minute to 2 minutes, 3 to 4 times a day. Now that's going to have a beautiful force loading where it's derotating out the thoracic cage, but it also empowers the patient. Yes, sir. Oh, I thought he was asking a question. He was just playing. So when you look at this, and to cross that plastic elastic change, but it's also changing proprioceptive firings because you're changing the pressure on those facet joints. So when you look at this one, this is for the lower one. So instead of, think of that scapula pivoting, for the lower thoracic, it's going to be down flat. So it's just going to be like that. When I tell the patients, it's hold your arm in tight, bend it up. And they'll go like this. No, hold it in tight, bend it up. Okay, and so you can gauge that by the movement of the scapula depending on the force loading aspect that you need on that thoracic cage. So now this is brilliant. How about we turn sitting into therapy? Okay, how about we empower the patient? Now, you all know the dental roll, fantastic. You're not going to get anything better. Now, do you remember way back to biomechanics, the plastic elastic deformation curve? I know, isn't it fun? All that stuff that you didn't think that you were going to really need, you really need. So, so you need 18 minutes of consistent pressure in order for the human body to maintain that shape. Okay, so how long do they have to do these exercises for? 18 minutes. Okay, and it's really simple. A rolled up towel in the convex portion, but also a rolled up towel or a water bottle, and what I tell them is the bottom of the elbow is the bottom of the towel. And now how long do they need to keep it back there? 18 minutes. Okay. So I say, look, keep it in there for 20 minutes, take it out for 10. 20 minutes in, 10 minutes out. So this way you turn driving into therapy. If they're an accountant, you turn sitting into therapy because you're not going to get them to not do the office job. This thing here, and it's all has to do, when you put that towel up high above where the lumbar support is, you rock that pelvis forward, you reposition the chest, you're restoring the curve. Plus, since you're doing it, if you're lucky enough to have them do it while they're driving, you get that vibratory aspect, which stimulates, okay, everything. It changes proprioception, it vibrates the ligaments, allows more nutrients in there. How do discs get their nutrients? Through imbibition, through movement. So this is everything, everything. And then you've got the neck curve exercise. Now this, the more that you can get people to do, you were all taught the towel exercise, right? Okay. I invented the TheraCurve. Wait, I need like, yeah! Okay, no. This is very simple. I know, it's a piece of pipe tubing on the inside surrounded by nylon and just very, very simple. This is the towel exercise. And all they do is put it around their neck, pull straight down, point the chin to the ceiling, look straight ahead and relax. So chin to the ceiling. And I say, look, if you feel like you're not doing it correctly, okay, or you're not doing it too forceful, exactly. This is a ligamentous exercise. This is something that I designed. So what do you do with patients with carpal tunnel syndrome or rotator cuff problems or scoliosis? You empower them. You know, oh, the headache came back. Where do headaches come from? Do you have a headache? No? Here. I know. So where do headaches come from? 97% are cervicogenic. They come from the neck. So you empower patients. Okay, now what I want you to do, sir, do this, okay, do it about 5 to 10 times every hour since you're on the computer all the time. Okay, do it 5 to 10 times every hour. So it empowers the patient, and it's so simple and easy. And it honestly, it cost me about $6 to make. I tried to get a patent on it, and I found out that you couldn't because I've been giving them away and selling them way before I applied for the patent. So who cares? So just give them away. And then when they use it at the office, what are you doing? Oh, I'm restoring the curve of my neck. I found out my headaches were coming from the neck. What are you doing? Oh, at work. Okay, oh, I'm getting rid of the numbness in my hand. Turned out those nerves were pinched. Here's my chiropractor's card. Huh? I'm sorry, did you hear the ka-ching? Okay. Okay. Okay, this is ideal. The ball chair is the best in the world, okay, because when you're sitting, the pressure on that disc increases 5 times normal. You've got someone who's an office worker, okay? What are you going to do? So the ball chair is ideal. Why? Because your legs are out wide, and you're always, since it's an unstable surface, you're always moving just a little bit during the day. Because do those discs have a good blood supply or a bad blood supply? Horrible. The blood vessels would be crushed, so it gets its nutrients through imbibition or through movement. So if you're able to just move that pelvis just a little bit, okay, it's going to stabilize and hydrate the discs. So when you look at this, you're going to put the rolled up towel on the convex portion. Now this is probably the coolest exercise ever, because when you get a kid, what's your favorite TV program, okay? For me, it was Bugs Bunny Roadrunner, okay? Okay, you got to sit down in front of the TV for 20 minutes. Can you do that? I know, you get compliance, okay? You know, but what it does, plastic deformation. If you are doing a lumbar scoliosis like this, you're going to have a pillow in between the legs and a pillow on the head so they're comfortable. But it makes a huge difference. Okay, now here's the right leg drop. The right leg drop is incredibly important. Or left leg drop. Okay, now let's say that you have a scoliosis like this. Okay, let's say you've x-rayed and you found out that the legs are level. Okay, that the legs, because when you take an AP lumbar spine, hopefully you're getting the top of the greater trochanters, because that you'll be able to measure the leg height down to the bare noogies, okay? Because that femur's hitting the tibia, that's hitting the calcaneus and the talus, that's hitting earth. So that's going to tell you if the legs are long. Too many people are misdiagnosed with a short leg. So what you do, you actually want them to bend into the convexity. Ideally, they're doing it for 18 minutes. But so if they bend off to the side like this, do you think that might negatively affect some other aspect? Yeah, I mean, you know, this even looks weird. Okay, so what you want them to do, and you'll see this, I even tell them, like the person in the middle, you're talking to some people like this. I mean, I'm from, Huntington Beach, LA. They're not bad, okay? They're trying to drop their shoulder, lower their hip. They're standing that way because it's comfortable. So you look at them and you can say, my God, biomechanically, your nervous system is so stressed. Why, what do you mean? You don't see what I'm looking at? Good God. Okay, so what you do is, let's turn it into therapy. So if you stand there, and this is a tough one to demonstrate, but your pelvis is level, you stick your right leg out, and then you drop the leg down to the floor. Boom, just like that. Okay, and to demonstrate, you can have, they can have some kind of support where they stick their right leg out and then drop it to the floor. So you're just dropping the pelvis. That's all you're doing. You're not stepping forward or anything, and they're just dropping the pelvis. And they hold this minute, 2 minutes, 3, 4, 5 times a day. And all it does, it empowers them because it instantly takes the pressure off. No, you're supposed to say, cool. Good. I know. It's so neat because, the more exercises you give them, the more effective it is. Oh, this is the moneymaker. Okay. I'm sorry. This is the trochanter support. When you have somebody who has any time they've been, they get adjusted, an hour later the pain comes back. Okay? It's an unstable pelvis. If you have anyone with a scoliosis, it's an unstable pelvis. If you have anyone that walks in high heels, it's an unstable pelvis. Now, chiropractors are fantastic at adjusting and getting a segment that's not moving correctly to move correctly. What if a segment is moving too much? Okay, can I borrow it? Okay, I happen to have somebody that told me she might have an unstable pelvis. Oh, I do. Okay. Cool, so just go face down, miss. Okay, now what's neat is during the exam, you always, whatever your exam procedure is, at the end of it, come down, approximate the limbs. Does that change the symptoms or feel a little better or no difference?
A little better.
Okay, good. So that right there, name the muscle that crosses the posterior aspect of the SI joint. Correct answer, there isn't one. Oh, I know. Can you imagine having me as an instructor? Ooh, nasty. Okay, good. Okay, you can stand up, please. So what happens is I tell the patients, okay, there's no muscle that crosses the posterior aspect of this, so it's a perfect joint. It never wears out. On you, it's wearing out. Now, that only happens because of long-term low back problems. Now, what I'm going to do, I'm going to give you, because my protocols are the same as yours. I don't adjust on the first visit. Okay, but she's hurting. Okay, she's been to a bunch of other chiropractors. What makes you different? Okay? Okay, now this, right after we just take the x-rays, we go in and I demonstrate this. Now, this is a band you're only going to need for about 3 to 4 weeks. It takes about that long to stabilize the joint. But the joint is only breaking down because of long-term low back problems. Okay, so where it goes, the top of the ilium is right there. This goes 1 inch below. And so that's one pull This is the second one. Okay, then walk around and tell me how that feels. Yeah.
Electronic clicking.
Yeah, yeah, that's going to actually stabilize it. Yeah, 100 times out of 100, they'll say, wow, that feels better. I know, it has to. So now this too, now sitting is going to be damaging for you. The way this comes off, you take it off like that, then you have to loosen up these belts first, and then it goes on just the way I showed you. Now, do you sit at work? Okay, good. What I want you to do is sit facing me like a cowgirl. Instantly, that feels better. I know. And see, when you do this stuff, they go, wow, how did he know? Because, I know, it is. Okay, because what you're doing is you're getting the legs out, you're approximating the hips, and you're taking pressure off that SI joint. So if you're working as a secretary, just sit like a cowgirl. Because again, it's only a dysfunctional SI joint, super easy to fix. But I'm going to find out why it fixed. And this is commonly missed by most chiropractors. But I'm like those Chiro One guys back in Chicago. Only I'm just in Huntington Beach. I'm like Chiro 2. Okay, you're set, thanks. And you can keep the belt. I know, isn't that fun? Okay, next. Yeah, okay, now here. This is huge. Now, I usually do the foot on a brick stretch, okay? Last Christmas, see, December's for me had always been like the slowest month, okay, until last year I decided to not make it. This Christmas, we actually increased our practice 42% in collections, which is why? Because I decided to change it. This was one of the presents I gave out. I know it's technical. This is a block of wood. It's actually a 4x4. Okay, I cut it. I had my son stamp it. This is our logo and our contact information. This side is the instructions on how to utilize this. Okay, now, unstable pelvis, chronic low back problems. Is anybody here that has that? I should have actually used you. Oh, good. Okay. Sorry to make it come up again. Okay. Now this is cool because what happens is, and you'll see that on the upper right, I do call that a good shoe. I come from 3 sisters and a mom, and my mom used to wear high-heeled tennis shoes, okay? You're not going to tell attractive girls to not wear high heels, right? Okay, yeah, because, I mean, it makes the legs look longer, the butt stick out, attracts guys like crazy. But what happens is it keeps the foot at an angle, okay? And the way you're supposed to walk is you're supposed to dorsiflex your foot. And if you can't dorsiflex, you're going to walk with your pelvis, which it looks great. Okay, I'm a fan. But it's going to destabilize the pelvis and it's going to be uncomfortable. So what I want you to do, okay, is you're going to put your heel on the ground, ball your foot up like that, and then you're going to bend your knee, okay? So here, give it a shot. Okay, and put your foot at a steep angle. Yeah, then bend your knee. Okay. Oh, good. That's not bad. Because normally a knee should go over here. What you're going to see consistently, and this is with like cheerleaders, this is with tennis pros, this is with people, yeah, and put it at an extreme angle so it's real steep. Because this is more common, you're going to see they can't even bend it. Okay? So you hold this a minute to 2 minutes, 3 to 4 times a day. And this was my present that I passed out, okay, last year. And I wrapped, of course, a coupon for $20 exam around it and said, here's your present, give it to a friend. But now, if somebody's pelvis is hurting, were you not wearing the belt at the workout? You know, did you do the foot on a block stretch? You know, so not only it empowers them, but also they know it's tools. And they got to hold this a minute twice a day. And I say, you know, put it where you brush your teeth. Thank you. Here. No. Here. I thought about throwing that, but I thought it would be bad. Okay, then you look at this. I mean, thoracolumbar junction, 67-degree curve. How do you tell if you can correct it? You bend it. I mean, see how simple it is? So when you get someone and you say at the initial exam, if we bend it and it doesn't change, we're not going to be effective. Her curve went from 67 to 51, okay? And that's only, I think, what, a year and a half? But it does take about 3 to 5 years to get the maximum correction. And she's doing the same thing. This one was really frustrating, Okay, for the $50,000 question, before and after, what do you see wrong with the first one? Okay, the pediatrician wanted to put steel rods in her. She had sweatpants on. She was standing like this. She had a hurt knee. Okay, and wasn't telling anyone. It just wasn't working right. The knee was really, really short on that one side. Okay, so I fixed the low back. I told her biomechanics of the knee, regrew the cartilage in the knee, and that's her on the right. So I mean, don't get confused. And they really wanted to put steel rods in her. It's just that's barbaric. Same thing again. Initial 64-year-old nurse, 7 surgeries. You can see the pre and post. Okay, so if someone's had surgery, they're working in the wrong place. Okay, at least over 80% of the time. So absolutely, you can help them. This guy, 2 Harrington steel rods. Okay, that's before and after. And you can see, I mean, this upset him because even with steel rods, can you still correct the curve? Yeah, how do you do it? You restore the lordata curve. That changes proprioceptive firings. I mean, it's always. Linda, scoliosis. Again, she had loss of dorsiflexion, so her pelvis is completely unstable. She's been to multiple doctors. And at 68, she bent down to 14. Her post x-ray was at 27. Now, her orthopedic surgeon said, well, it got better. It can't really get better, so it's going to get worse. Why would he be so stupid to say something like that? What do they do for people in pain? What do they give? Say one: Motrin, Advil, Tylenol, Naproxen, naproxen. Okay, non-steroidal anti-inflammatories, do those inhibit proteoglycan production? Yes or yes? If they do, they destroy joint cartilage. So the orthopedic surgeon, every patient, every day, he gives them something that destroys joint cartilage. So when he goes in there and says, wow, we can't regrow the cartilage, no kidding, if I passed out something that destroyed joint cartilage, I would never see it too. It doesn't make any sense. This is Linda, the same thing. You can see it on the lateral cervical. She had a surgery, and the surgeon said, good God, don't let anyone touch your neck. You'll get paralyzed. I know. If you flash your lights on the freeway, you're going to get a gang shooting. Okay, so what do? You take a stress x-ray, okay? I heard of all those urban legends. But this way I can go in and say, look, the guy's probably really good with a knife. He's not familiar with restoring curves naturally. Okay, he doesn't understand neurology. So again, you can fix it. And this one here, those steel rods, this gal is 26, I think. Chronic low back pain. She'd been to every physical terrorist on the planet. They did every kind of ultrasound on the planet. They did, everything. She went to a chiropractor that didn't take x-rays. That doesn't make sense. Working blind? Look at their leg length different. Almost an inch shorter, okay, on one side. No one caught it. So what do we do on the first visit? She comes to us after the surgery, and my God, these rods are like this. There's only a few vertebrae I got left to work with. Guess what she said when we put the belt on? Ah, exactly. I know, it's like the IST commercial. Okay, and then this is her top portion. Those rods go a long ways. But stabilizing the pelvis, we were also able to correct it, able to get that area, get that low back as stable as possible. This is why you've got to, this gal's life is going to be negatively impacted forever. Do you think that we could have corrected this? Yes or yes? Absolutely. There's no doubt in my mind. Gee, if you didn't even adjust, you just stabilized the pelvis and gave her something to level her pelvis out. The basic doctor on the planet would do it. This is a challenging case, 13 neck surgeries, and she had brachial plexus symptoms. Remember where the brachial plexus comes out? The middle of that hardware. Okay. Now what's interesting is I actually asked her, one of the most brilliant doctors I ever knew, he said to find out what's wrong with a patient, you have to do 2 things. You've got to ask them, and then you got to listen to them. I know, the second part's harder. Okay, so I said, what do you do for relief? She says, well, I have this traction unit that lifts me up. So I actually got her occiput, not a thrust, for God's sake, with that. Okay, but applied a little force. She felt relief on the brachial plexus. Anyone want to know why? I'd like to too, because in my mind, I'm looking, this is why you can't be confused, okay? Don't prejudice yourself. When you're looking at nothing but hardware on top of hardware, 13 neck surgeries, ask them, what moves better? I mean, you know, this is a nightmare, okay? The 6 mobile vertebrae, I think they're supposed to be, what, 24? Okay, you know, I mean, and then when they fused his neck, they fused it in a kyphotic curve. We have to do this, okay? Those lives are negatively impacted from ignorance, okay? They're either ignorant or evil, and I, honest to God, think they're just ignorant, okay? And we're the only ones that can help them. There's no other doctor on the planet than us. There's nobody else that can conservatively correct a scoliosis. You're not going to do it with ultrasound. You're not going to do it with anything other. I mean, I'm a little. Next talk I'm going to do in battle armor. Okay, so, you know, go, you know, check out our YouTubes. All of these talks, I got them. I got them on a DVD showing me the talk. I got the PowerPoint that you can customize. I got all the handouts. If you have any subject on anything, email me. Okay, if it's anything to do with health, I'll build you one. Okay, I mean, it's because we're always looking for new stuff. The ones we got coming out now are all the adjusting videos. So a lot of this stuff I go over, but I'm trying to pack it in. So it's a lot of very, very fast neurology, you know, proprioceptive stuff. You know, I mean, you know, you gotta have a level of education to watch them. Where most of them are down for the general public, but the adjusting videos, they're going to be up at a little higher level. Okay, so email me, contact me in any way you can, and honestly, thank you so much for inviting me out. This has been so much fun. I really appreciate you guys.